us. Um, Recording in progress. Got it. All right. I'm Cynthia Holland-Hall. My partner in crime, Dr. Sarah Pitts. Well, let me move along here. So welcome to what we hope will be the first of many educational activities hosted by the Adolescent Medicine SIG of NASPAG. Again, my name is Cynthia Holland-Hall. I'm an adolescent medicine doc at Nationwide Children's Hospital in Columbus, Ohio, and Ohio State University. And I'm really excited to be here with you today doing this. My partner in crime, Dr. Sarah Pitts from Boston Children's and Harvard Medical School, is joining us tonight. She's going to be monitoring the chat for questions. She'll interrupt me if it's a quickie and it seems appropriate. Others she might hold off till the end. But we are here tonight. Sarah and I are kind of joined forces to reinvigorate sort of the adolescent medicine special interest group in NASPAG, which has had a couple of different iterations through the years. And we are so happy that you're joining us, and we encourage you to join the Adolescent Medicine Special Interest Group through NASPAG. It's a great way to connect with other adolescent medicine, reproductive health providers, participate in these kind of educational offerings, which we're hoping to be a quarterly series, and a great way to just get involved in NASPAG. Adolescent medicine has historically had a really strong presence in NASPAG, and we want to maintain that as pediatric and adolescent kind of gynecology kind of grows and blossoms as a field with a lot more fellowships. It's a wonderful thing, but we want to keep adolescent medicine strong within NASPAG because we really bring an important perspective. So we want to just keep as many adolescent medicine people engaged and involved as we can. So if you're interested, just go ahead and throw your email in the chat, and we'll keep track, and we'll start we'll add you to the list of interested people in adolescent medicine. We got to keep adolescent medicine NASPAG. You know, the adolescent medicine are the docs who bring the fun, right? So my slide doesn't want to advance. There we go. So two shameless plugs before I get started. The first is Dr. Arij Hassan has agreed to present the next talk in this series on, and it'll be, the exact date hasn't been set yet, but it's going to be in January. We're hoping for this to be a quarterly series, and she's going to be talking about popular vulvovaginal trends, which I'm excited to hear about. I think it's going to be really fun, engaging presentation. So keep your eyes and ears tuned to find when we get to a date for that. And of course, plugging the annual clinical and research meeting of NASPAG, which is going to be in April of 2022, the 7th through the 9th in Chicago. NASPAG is always a great meeting when it's in Chicago. And so I hope that we're all in person. I can't wait to see old friends and meet new. And we will have an adolescent medicine SIG meeting while we are there, as we do every year. All right, I have no disclosures, and moving into the content. So looking at our agenda for today, move my picture here. I kind of wrapped up the objectives and the agenda all into one slide here. So at the close of this presentation, participants will be able to name 3 or more changes in the new CDC STI Treatment Guidelines that came out about 3 months ago now. And we're going to start by talking about some changes that have been made to screening guidelines, changes in the treatment of gonococcal, chlamydial, mycoplasma, and trichomonas infections, some updated guidelines for the treatment of pelvic inflammatory disease. And then we're going to talk something that's got a little bit less attention, but I think is really interesting, is some changes in testing and counseling around herpes infections. So we're going to talk about all these things and hopefully have lots of time left over for questions. Just a slide or two on epidemiology, because I think I'm probably preaching to the choir on most of this, but we know that keeping it in context, over half of young people have sex before they graduate high school, with 18% reporting that they've had 4 or more sexual partners by their senior year. That's data from among high school students. And then by their early 20s, the vast majority of young people are sexually experienced. So we have seen small decreases in the rates of sexual activity over the past several years, but unfortunately, condom use has also been decreasing. Within the last Youth Risk Behavior Survey, only 54% of high school students saying that they used a condom the last time they had sex. So we're going to keep seeing STIs. And before this little thing called COVID kind of took over all the infectious disease headlines, these were the headlines. Actually, it was kind of a big deal that sexually transmitted diseases cases were rising. Reported cases of gonorrhea, syphilis, and chlamydia were all kind of hitting these record highs. And then kind of COVID came in and squashed those headlines. But also brought down briefly the rates of diagnosis of STIs, not necessarily the rates of STI, the prevalence of STIs, but the rates of diagnosis, which now we don't have the CDC surveillance data out recently yet, but well, I suspect things will be right back up where they were very soon, if not already. Just a quick reminder that many sexually transmitted infections, as illustrated for chlamydia here, are diagnosed most frequently in our NASPAG population, our adolescents and our young adults, and particularly not our little kids, fortunately. But for those, who are like, oh, is this really a pediatric problem? Is it more of an adult thing? Well, young adults, yes, but absolutely teenage patients, really some of the highest rates of chlamydia and other STIs as well. So this is absolutely a pediatric problem. So every 3 to 5 years or so, us STI nerds get very excited about the release of the new STI treatment guidelines. And this edition was particularly highly anticipated because there was a delay in the release of a good year or so due to the pandemic. But they were, again, released in the end of July, now available on the CDC website. Along with the full monograph, you can download a pocket guide, you can download wall charts. They're all available on the CDC website. One of the most useful tools historically was always the phone app. The updated version of the phone app is not released yet. It's not quite ready yet, but it will be available, and that's very handy. Even now, if you go to the CDC website, they give you instructions, or a lot of you probably know how to do it already, to just get to the website. And if you get on the mobile website and then just put a little, download the little icon to your screen, your home screen of your phone, it basically functions like the app. So it's very handy. So they'll walk you through how to do that if you're not sure how to do it. And it functions a lot like the old app did, but the app will come out. So although it's called the treatment guidelines, it does contain, as many of you know, much more than simply treatment instructions. There's how to take a sexual history, screening guidelines, what tests to use, sexual abuse evaluations in children and older adolescents, and a whole lot more. So it's a really very valuable resource. The authors of this make a point of reminding us again that this is a guideline and it should be regarded as a source of clinical guidance rather than, as they say, prescriptive standards. And I think that's important when we talk about some of the changes that have been recommended, is that, keeping in mind that we do have to engage in some shared decision making with our patients about how we use these guidelines. So in this talk, in an effort not to clutter my slides up too much, I have not included a lot of references for all the statements that I make, but this document, the guidelines include, it's heavily referenced, and it will lead you to the references that support the recommendations that I'm going to discuss. So the first change that a lot of people noticed is it's finally not called the STD treatment guidelines anymore. It's now the STI treatment guidelines, reflecting, of course, that we're not only concerned about disease, but asymptomatic infections as well. So let's talk about screening first. Chlamydia and gonorrhea, of course, the two most common reportable infections, usually asymptomatic, but when they are symptomatic, they can be highly symptomatic, causing cervicitis, urethritis, pelvic inflammatory disease, epididymitis, not so much epididymitis in our NASPAG, in our GYN patients, but again, as an adolescent medicine doc, I'm going to mention males just a bit in this talk as well, because, most of us adolescent medicine providers, of course, take care of both male and female patients. In females in particular, of course, the risks of infertility, ectopic pregnancy, chronic pelvic pain, increased risk of HIV acquisition, all of these sequelae of STI can have really high morbidity associated with them and a high financial cost as well. So this table summarizes the guidelines issued by CDC, the American Academy of Pediatrics, the Society of Adolescent Health and Medicine, ACOG, USPSTF, and they all have their own guidelines. Many of them are based on the USPSTF guidelines, and there are subtle differences between the guidelines, but they all are basically a lot more alike than they are different, and they're kind of summarized here. So all sexually active females, of course, under 25 years of age should be screened for gonorrhea and chlamydia. Young men who have sex with men should be screened regularly. The sources of testing for young men who have sex with men should be based upon their sexual practices. So urethral in most people, rectal if they engage in anal intercourse, receptive anal intercourse, and pharyngeal if they engage in receptive oral intercourse. And you can see the other guidelines there. Mostly they differ in terms of testing in heterosexual young men, with AAP and SAM being the most permissive about testing young men for gonorrhea and chlamydia. So adolescents with multiple risk factors may be screened more often than once a year, of course. And again, recall that adolescents can consent to their own testing and treatment for STIs in all 50 states without parental involvement. So what's new in screening recommendations? I've indicated some of the changes in red, so they kind of jump out at you here. So while there's still no guideline recommending routine pharyngeal testing for young women for gonorrhea, there is stronger language now in the form of a sort of permissive statement that now supports considering this testing based on sexual practices. So pharyngeal testing for gonorrhea was, of course, already recommended, as I mentioned, for young men who have sex with men who engage in receptive oral intercourse, now encouraged, or at least to consider it, for females who engage in oral intercourse as well. Similarly, there's a recommendation to consider rectal testing in young women now for both gonorrhea and chlamydia in females who engage in anal intercourse, as is the recommendation for young men who have sex with men. And what's really interesting is that there's data now that shows that young women have significant rates of positivity for chlamydia at the rectum, even if they do not endorse having engaged in anal intercourse. And it's believed that this was by auto-inoculation from the vaginal area, from the genital area to the perianal area. So even in the absence of a reported history of anal intercourse, significant numbers of young women are testing positive for chlamydia at the rectum. So screening should be considered. One of the things that I think is of particular interest to pediatricians is that providers consider a new recommendation that providers consider adopting a practice of opt-out screening for sexually active for all adolescent females, in which the patient is notified that testing will be performed unless she declines and doesn't want testing. Now, this recommendation, or this approach, is already recommended for HIV screening. That it's, we kind of do opt-out screening. We test all of our patients for HIV, and of course, if a patient doesn't want it, they can opt out. So now that same approach is encouraged, that we at least consider it for gonorrhea and chlamydia testing. Data suggests this may be cost effective and may increase the rates of screening and detection, not surprisingly, if we test everybody, including people who perhaps don't want to disclose their sexual activity. Of course, it's still important to ask about sexual activity, but some may find it useful to have a sort of across the board practice that includes screening of patients who do not disclose sexual activity. This is something I haven't personally started doing in my clinical setting. I have a lot of questions about kind of how confidentiality would be managed, but I'd be curious later on when we're doing when we're kind of talking after to hear if people have started doing more of an opt-out approach already, or sort of routinely testing, and how you kind of handle that.
Real quick, in the chat, there was a question. I don't have the numbers for this, but you may. How often would you have a positive anal and negative vaginal test if they do not report anal sex? And I would suspect it's pretty low, but.
Positive anal, negative vaginal if they don't report it. Yeah, I don't know offhand, but the speculation, and we don't know that it's auto-inoculation, but that's sort of the presumption. So no, I don't know what those numbers would be, and I suspect there's not a tremendous amount of data on that at this time, but hopefully more amassing. So screening, just to kind of review, screening recommendations and considerations for other STIs are listed here. So females who are at increased risk of trichomonas, such as incarcerated females, or if you just happen to see it a lot in the community you take care of, still no universal trichomonas screening guideline from CDC other than for incarcerated women and women with HIV. So I think a little bit of disappointment to a lot of adolescent medicine docs, still not a routine screening test for young women. No role, no utility for screening young men for trichomonas. Syphilis, of course, young men who have sex with men should be screened, others according to geography or specific risk factors. Changes in HPV recommends screening for HPV. So as many of you know, I'm sure the American Cancer Society came out last year with a recommendation that screening for HPV, rather than doing pap smears starting at age 21, which is of course our current practice, that screening be deferred until 25 years of age, and the test used then be HPV nucleic acid amplification testing. So that's from American Cancer Society. USPSTF and ACOG still endorse starting, routine screening at age 21 using a pap smear. And then of course, immunocompromised young women should be screened using a pap smear when they become sexually active. CDC in the guidelines reported both of these recommendations. They did not endorse one over the other. So that's for us to decide. Screening for HIV.
Sorry to interrupt, but that's my job. There was a question about how to obtain rectal swabs for GC, and is it separate swabs? And at least at our institution, it does matter the swab, so we can't use the vaginal swab. We have to use the cervical swab at our institution to do the PCR for the anal GC chlamydia testing. And then we have to label it as such specifically. So I think it might be institution variable, but Cindy, I'd be interested to hear from you.
I agree, institution and lab variable. So there are, I believe, some NATs that are now FDA approved for non-genital testing. But in addition to that, many individual labs, either at academic centers or some of the big labs like Quest and LabCorp, have done internal validation. So you can use your Aptima or your BD, on rectal swabs. So it's definitely worth a phone call to your lab to figure out exactly in your setting, what test can I use, which one? Because yes, things that don't make sense, that you can't use the vaginal, but you can use the cervix in the collection kits in the vagina. But you know how it is. If you do the wrong one, your lab's going to toss it out, right? At least my lab's going to toss it out if I collect the wrong thing in the wrong kit, even if I know it's just a different swab and everything else is the same. So definitely worth a phone call to your lab to sort that out. And you might have more options than you think, because even if they don't do like an FDA approved test, again, a lot of labs have done kind of internal validations so that you can use the nucleic acid amplification test in your lab, even if it hasn't been FDA approved. So talked about what to test for, how are we going to do the testing? In most resourced settings that we practice in, we really should be using nucleic acid amplification tests to screen for gonorrhea and chlamydia. Again, there are several tests available that are FDA approved using the various technologies listed here. Most are approved for use with urine, vaginal, cervical, urethral swabs. Again, some approved for non-genital testing as well. Oh, and I should mention, in men who have sex with men, there's good data that self-collected rectal swabs are as good as clinician collected. I don't know that I think it has not been published for women collecting rectal swabs at this point, but that could be coming as well. So self-collection might be an option. Again, some of these, such as transcription mediated amplification, are approved, which is Aptima. Those are approved for trichomonas testing as well. So important to learn which test your lab uses, again, and what specimens you can send. So most primary care providers and lots of us use urine testing. It's so easy. It's a great convenient way to test for gonorrhea, chlamydia, and trichomonas in women, and gonorrhea and chlamydia in young men. But to maximize the sensitivity of urine testing, you really should collect it properly. It's a little bit more than just pee in a cup, right? So you want it to be, for the first catch urine, does not have to be first thing in the morning, but for the first catch, referring to the first part of the urine stream. So it should be at least an hour since the patient last voided. Should not be a clean catch specimen. I think most people get that one. You actually want that kind of dirty urethral washout to get a high yield, right? First 5 or 10 mLs of urine stream only, ideally into the cup. We know they're going to give us what they give us, but ideally you just want the first 5 or 10 cc's in the cup and the rest into the toilet. And that can be left at room temperature for 24 hours. Longer than that, just throw it in the fridge. So urine is extremely convenient and it works really well. I do always like to point out that vaginal testing using either clinician collected or self-collected vaginal swabs performed by the patient in private increases the sensitivity for chlamydia by close to 10%. So it is recommended by AAP and CDC. They both really endorse vaginal testing. And I'm just going to take one little tangent because this is a pet issue of mine about why vaginal testing is preferred over urine. Urine's great. And if urine's what you got, I'm not trying to dissuade you from using it. But I want to show you some of this data. So these are all studies in which all of the women, the ends in each one, all of those women were positive for chlamydia trachomatis. And then they tested each woman at the cervix, the vagina, and with a first catch urine. And again, this is a like per protocol research collected urine. So this probably is the optimal kind of urine specimen, maybe a little different from what we sometimes get in our clinics, right? And you can see that when they went from cervix to vagina, we really didn't sacrifice any sensitivity with the vaginal swabs compared to cervical. But when we go to urine, we do see the sensitivity drop a little bit. Still respectable, 88%, 92%. But this is why vaginal swabs are considered a little bit better than urine. So if you're in a setting where it makes sense to use vaginal swabs, I encourage you to do that. This one here, this is a microbiologist. She has to have been a microbiologist because she studied rather than sensitivity. She reported organism load, these elementary bodies per 100 microliters. These numbers don't have any clinical meaning, certainly not to me. Maybe to some of you they do, but I can still appreciate, you know, that the order of magnitude of the organism load goes down dramatically when you go from cervix to vagina to urine. So think about if it makes sense in your population using more vaginal testing. Okay, back on track. So focusing on chlamydia for a moment. There is evolving information about rectal chlamydia in young women, as I said, in addition to young men who have sex with men. So again, rectal infection well described in those who engage in receptive anal intercourse, but in addition now chlamydia can be identified in rectal testing of women who deny anal intercourse. Therefore, as I mentioned before, rectal testing should be considered in young women. There are now FDA-approved NATs for extragenital testing. And as I said, self-collected rectal specimens have comparable sensitivity to clinician-collected specimens in men who have sex with men. And I suspect that will be the same in women if we get that data. Doxycycline, we now know, is superior to azithromycin in eradicating rectal chlamydia. And that has been a driving force behind this really big change for a lot of us. Doxycycline now being the recommended treatment for uncomplicated chlamydial infections, with the single dose of azithromycin now knocked down to alternative treatment status. So again, for years now, we've had data on the superiority of doxy over azithromycin for men who have sex with men with rectal infection. Now, evidence for women as well. Recalls cannot be predicted by reported sexual practices. In women, the efficacy of azithromycin for the treatment of rectal infections was 78% for the azithromycin versus 95% efficacy for the doxycycline. So doxycycline, 100 milligrams BID for 7 days, now recommended over our old favorite of azithromycin in that nice, beautiful single dose treatment. And I think this is the recommendation that's probably caused the biggest buzz in the adolescent medicine world and in the STI world in general. Obviously, great appeal of single dose treatment with azithromycin with regard to adherence and completion of therapy. You can just give it to her right there in your office. You know, she's treated, she's appropriately treated and her therapy is over. And this is where I'll remind you, these are guidelines. You need to make the best decision for your patient, but I would encourage you to use the choice for which we have the best efficacy, the best evidence of high efficacy whenever possible. And I'm a little bit concerned with people just saying, oh, well, teenagers, they're never going to finish their antibiotics. I'm just going to keep using the azithromycin. You might have patients in whom that is the right decision, but I think we have to respect our patients enough to really believe in their desire to get treated adequately, and engage in shared decision making, saying, I really want to offer you the very best treatment for chlamydia, which is an antibiotic that you'll take twice weekly or twice a day for a week. Let's give that a try. If you do have trouble taking it, it upsets your stomach, you think you can't finish it, call me. And then, it might be reasonable to consider the single dose azithromycin. But I think we need to not assume that adolescents can't do it, which I'm afraid might happen in some settings.
Cindy, sorry, can you repeat real quick the numbers again for Zithro versus Doxy? Was it 78% on Zithro?
78% for azithromycin, 93%, I think it was, for doxycycline, 95% efficacy for doxycycline.
Okay.
For rectal.
You might get to this about EPT, but if not, at some point, if you could mention the EPT recommendations, because certainly Zithro is a lot easier for that.
Yeah, so EPT doesn't actually recommend antibiotics, right? They recommend, specific antibiotic regimens. So obviously, again, a single dose of azithromycin is extremely convenient for expedited partner treatment as well. And you might consider still using it, but we have changed our practice that EPT, we're prescribing doxycycline as well. We give prescriptions. Unfortunately, we don't dispense medication for partners. So I think the EPT recommendations, the process of EPT is separate from the specific guideline for what antibiotic you choose. And I think the recommendation would be to choose doxycycline, but again, engaging in shared decision-making on that. Doxycycline is available as a delayed release 200 milligram tablet with once daily dosing that is likely to work as well, fewer GI side effects as well, but I suspect it's going to require prior auth and probably isn't going to be widely available to all of our patients. And azithromycin is still recommended in pregnancy as well. So antimicrobial resistance of Neisseria gonorrhea is still a concern. Right now, we're in a stable place with this, not necessarily a great place, since ceftriaxone really is the only reliable treatment we have for routine use for the treatment of Neisseria gonorrhea. So kind of walking across a very abbreviated timeline here, fluoroquinolone resistance now pretty widespread actually. And so the quinolone resistance is limited in the treatment of gonorrhea. The use of the recommendation for the use of quinolones is very limited in the treatment of gonorrhea. Then we saw emergence of resistance to the oral cephalosporins and some increases in the MICs for ceftriaxone. So some indication that ceftriaxone might be becoming less effective as well. Therefore, in 2010, dual treatment of gonococcal infections using ceftriaxone plus azithromycin was recommended, and that's what we've been doing for the past decade. And this may have worked to slow the reduced susceptibility to ceftriaxone and the emergence of increased slow the emergence of increased resistance to ceftriaxone. So it does seem that the dual treatment worked in that regard, but there are a lot of concerns that exist regarding potential harm to the microbiome and other organisms, also the rapid emergence of macrolide resistance, which is definitely increasing. So the recommendation for dual treatment of gonorrhea with 2 antibiotics no longer exists. And the recommendation for the treatment of uncomplicated gonococcal infections of the cervix, urethra, rectum, all single dose, is ceftriaxone and a new higher dose of 500 milligrams IM single dose treatment single, monotherapy, just with ceftriaxone. For patients who are over 150 kilos, the doses increase to 1,000 milligrams. And that is also highly recommended as the treatment regimen for pharyngeal infections. So again, the routine addition of azithromycin is no longer recommended for the treatment of gonorrhea. Now, if you have not ruled out a chlamydial infection, you will still want to treat with 7 days of doxycycline if you have not ruled out chlamydia. But if you've got your NAT back, positive gonorrhea, negative chlamydia, just ceftriaxone. Cefixime, the dosing for cefixime, if you are going to use it as an alternative, has also been increased from 400 to 800 milligrams in a single dose orally. Again, really concerned about the emergence of resistance of gonorrhea to the oral cephalosporins. Particularly, the oral cephalosporins are particularly bad at treating pharyngeal infections, so you really don't want to use it if ceftriaxone is an option. The only time I would really consider cefixime is if you're calling a patient and they're literally refusing to come in for treatment. They say, look, if you call me in something, maybe I'll go pick it up and take it, but I'm not coming in, you're not giving me a shot. That's when I would use cefixime. It also might still have a role in EPT. For people who are like, my partner's no way going to come in and get a shot of anything, but maybe he'll take a pill if he gets a prescription for that. So alternative gentamicin, IM plus azithromycin is listed in the new guidelines as an alternative. So I spoke before about the concern for unrecognized rectal chlamydia infections driving the new treatment recommendations for that organism. For gonorrhea, it's the pharyngeal infections we're more focused on, as pharyngeal testing, again, not always performed, more of a permissive recommendation to do it now or to consider it more often, but still not always performed. And the oral cephalosporins, again, have a particularly low efficacy for treating pharyngeal infections. So if a patient's diagnosed with gonorrhea, say with a positive urine screening test, ideally, we should then ask them about, do you engage in receptive oral intercourse? And if they do, consider obtaining pharyngeal culture, pharyngeal testing in that patient to drive your treatment. Now, if they're going to come in and get a dose of ceftriaxone, then that's going to treat both. But CDC does encourage, especially if you're considering the use of an alternative regimen, if you can potentially get a pharyngeal testing with a culture or a NAT. Obviously, the nice thing about culture is then if it's positive, you can do susceptibility testing on it. So they're encouraging us to really think about more oropharyngeal testing. And so ceftriaxone, again, strongly recommended for the treatment of pharyngeal infections because the oral cephalosporins have a particularly low efficacy in eradicating them. And test of cure is now recommended for pharyngeal infections. No matter what you use, test of cure is recommended 14 days after treatment. And if the test of cure is positive, then antimicrobial susceptibility testing is highly recommended. And CDC is available if you're in this situation, you've treated for gonorrhea, you've got a pharyngeal infection, you do the test of cure, it's still positive. Again, get susceptibility testing. But if you need help from CDC, I think throughout the guidelines that they've been more explicit about how to access help from CDC, because they really do want to know about, for surveillance purposes, know about treatment failures and help you manage them.
Hey, Cindy, there was a question, same one I had, about when you treat retest 14 days later, isn't there a risk of having a false positive if you're using NATs like we have with
There
urine?
is. Yeah, and we get concerned about it with genital testing, of course. So there is, CDC actually says 7 to 14 days, which I just feel like 7 days, you're just asking for trouble. So that's why I listed it. I reported it to you all as 14 days. I think if you really look hard at the genital literature for genital STI testing, really the vast majority do clear that fast. And, we all, people hear about, oh, it can be positive out to a month. Yes, that has been reported, but really the vast majority of genital infections, genital positivity, even with the nucleic acid amplification test, they do respond typically within 14 days. So I don't think it has to be a huge concern. But it's a good reason to consider culture as your test of cure. Mycoplasma genitalium, still sometimes described as an emerging infection in the STI world. Of course, we know it's been around for a very long time. We've known about it for decades, but what's emerging is our understanding of Mycoplasma genitalium as a pathogen and our ability to test for it, right? So we now know that Mycoplasma genitalium is detected in addition to causing non-gonococcal urethritis. It is definitely pathogenic in that regard. Also, really strong association with cervicitis, up to 30% of women with cervicitis Mycoplasma genitalium has been detected in up to 30% of women with cervicitis and up to 22% of women with pelvic inflammatory disease. Now, of course, simply identifying the organism doesn't prove its pathogenicity, right? It could just be there colonizing or whatever, but we've got more data now, more research really indicating that Mycoplasma genitalium probably does have a causal relationship with cervicitis. It's kind of interesting that the researchers demonstrated pro-inflammatory cytokines. So in the presence, looking at women who have cervicitis, clinical evidence of mucopurulent cervicitis, positive for Mycoplasma genitalium, also have these high pro-inflammatory cytokines that can be measured. And when that infection is treated and the Mycoplasma genitalium is cleared, those inflammatory cytokines come back down to their baseline levels. So it really does suggest that the M. genitalium really was playing a pathogenic role in cervicitis, and believed similarly in the case of pelvic inflammatory disease, but with sort of less cool studies demonstrating it. So although we know that, FDA approved NAT testing for Mycoplasma genitalium has now been available for a couple of years, routine screening for this organism still not recommended by CDC. They continue to recommend testing for M. genitalium only with persistent urethritis, persistent cervicitis, persistent PID, not responding to treatment. Then it might make sense to test for Mycoplasma genitalium. No role for ureaplasma or Mycoplasma hominis testing in women at this time. There's no clear pathogenicity of those organisms that's been demonstrated in women at this time. So Mycoplasma genitalium treatment, azithromycin resistance is rapidly developing already for Mycoplasma genitalium, which leads to some fairly complicated treatment recommendations, as you can see here, based on whether resistance testing is available when the organism is identified. So CDC kind of went through this whole thing about if you've got, if resistance testing is available, do this, and if it's not, do that. Resistance testing is not available to very many of us. There's no commercially available product. If you happen to be in an academic center where they could do it, great, but it's not something that's widely available to most of us. So basically, in any case, it still is a complex treatment. So in any case, the treatment for Mycoplasma starts with, and this would be for like a cervicitis, there's a different regimen for PID, starts with doxycycline, BID, 100 BID for 7 days, followed by moxifloxacin, 400 milligrams daily for 7 days. If it is macrolide resistant, or if, as is the case for most of us, you don't know if resistance testing is not available, then it'll be a week of doxy, followed by a week of moxifloxacin. If you happen to know that it's macrolide sensitive, then you can use doxy followed by azithromycin. So kind of complicated, all in the guidelines. And then when it's PID, then it's moxifloxacin. It's still 400 of moxy for 14 days. That would be the treatment regimen for pelvic inflammatory disease, if you're suspicious or know that you have M. genitalium present. Talking a little bit more, just briefly about pelvic inflammatory disease, know that this is a polymicrobial upper genital tract infection, of course. Now, the upper genital tract, not that easy to get to, so we have to settle for lower genital tract STI testing at the cervix as our best proxy. Often, as you all know, no organisms are identified from our lower genital tract specimens. And with gonorrhea and chlamydia identified only about half the time, maybe even a little bit less than that. And now we do sometimes find Mycoplasma genitalium when we look for that. We know that anaerobes are typically present in the upper genital tract in the context of PID, and our treatment needs to reflect this polymicrobial infection with anaerobes typically playing a pretty big part. So the challenge of PID remains really that it is a clinical diagnosis. Our diagnostic criteria lack both sensitivity and specificity. So I therefore encourage you to get the most and the best information you can in the clinical setting when you're determining whether or not a patient has pelvic inflammatory disease. So of course, you're primarily looking for tenderness on your bimanual exam, but I'd encourage you not to fall into the habit, as I'm seeing in a lot of pediatric emergency departments, of using just a bimanual exam and a urine test, and that's what's getting used to evaluate for pelvic inflammatory disease. If at all possible, perform a speculum exam to visualize the cervix. We're the ones, if we're not doing it in NASPAG, who is going to keep doing speculum exams in teenagers, right? So if at all possible, get that speculum exam, look at the cervix, visualizing a healthy pale pink cervix versus an inflamed cervix with pus coming out of it, coming out of the os, is really valuable information to have when you're deciding whether or not PID is present. So I highly encourage it. Perform cervical or vaginal. You can do a blind vaginal swab if you don't have a speculum. Go to the source of the infection as close as you can rather than urine testing when you're evaluating for PID, if at all possible, to increase your sensitivity, get a better specimen. If you have access to a microscope, look at the vaginal secretions for evidence of inflammation. Get all the information you can. PID is a hard enough diagnosis to make with great certainty. Don't shortchange yourself when clinical information is available to you. So the recommended treatment for PID now includes anaerobic coverage in all cases. And lots of us were already doing this frequently, if not routinely, adding metronidazole to our antibiotic regimens, since that anaerobic coverage with ceftriaxone and doxycycline is poor. So in that outpatient setting, lots of us were already adding in Flagyl. And a recent study clearly showed that the addition of metronidazole to that outpatient PID regimen of ceftriaxone and doxycycline more effectively eradicates anaerobes from the upper genital tract. So treatment, 1 dose of IM ceftriaxone at that new higher dose of 500 milligrams, and then doxycycline and metronidazole in all patients for 14 days. In the inpatient setting, cefoxitin is one of the few cephalosporins that actually provides good anaerobe coverage. So in the inpatient setting, you can use cefoxitin plus doxycycline. But then when they go home, you will want to continue the anaerobe coverage by sending them home on the doxycycline and then adding in the metronidazole for when they're off of the cefoxitin. Other outpatient and inpatient treatment regimens using different cephalosporins exist. None of them really holds any great advantage over the regimens that are listed here. Some people, I'm seeing a little bit more use of ceftriaxone in the inpatient setting, which is fine. Ceftriaxone, again, great, probably our best against gonorrhea, but doesn't have the anaerobe coverage that cefoxitin has. So if you're going to use ceftriaxone in an inpatient setting, you do want to add in your metronidazole right away at the beginning of treatment. Either one's fine. My personal preference is I like to use cefoxitin and doxycycline. Leave the Flagyl off where their tummy's upset, or you can use it IV, but I just kind of tend to leave it off. And then when their belly's feeling a little bit better, then I'll transition them and add, with the oral doxy, and then add in also the metronidazole for when they go home. But however you want to do it is fine. Clinda and Gent has been demoted to an alternative status for parenteral treatment for PID. Trichomonas is a diagnosis that I treat frequently. It's a diagnosis that I know a lot of you treat frequently, very common in some populations, associated with adverse pregnancy outcomes, increased risk of HIV acquisition. And, although seeing motile trichomonads under the microscope is cheap and fast and relatively entertaining way to make the diagnosis, the sensitivity we know of microscopy is poor, and many don't have access to a microscope. So NATs are great. If you're in an acute care setting, especially, I think the OSOM point of care test for trichomonas is actually quite good. And once again, unfortunately, CDC has recommended moving away from single dose treatment for females with trichomonas infection. And now the guideline is for a full 7-day course of metronidazole 500 BID for a week, rather than our good old whopping 2-gram dose all at once. This longer regimen is associated with higher cure rates, fewer repeat positive tests 1 month post-treatment. So it's, again, unfortunate, but it's the better treatment for our patients. It's the more efficacious treatment for our patients. For males, metronidazole is still fine in the 2-gram dose is still the preferred treatment for young men with trichomonas infections. Tinidazole, 2 grams in a single dose, still approved as an alternative regimen for both males and females. Tinidazole compared to metronidazole, it gets higher, it achieves higher levels in the serum and in the genitourinary tract. So it is, and it's been shown to really be somewhat superior with cure rates compared to the metronidazole. So you can, if you use tinidazole, that still can be used in the single dose 2-gram dose. But again, many of us have had trouble getting it, obtaining it for our patients, getting it authorized, getting it filled.
Hey, Cindy, I have a tough one for you. Is there a recommendation for patients with a flagell allergy when treating trick? I'd have to look
Not
at the
that I
CDC
know
website.
of. Fortunately, flagell allergies are very uncommon, but I would actually contact CDC. This is another case where CDC is ready to help. Certainly, if you think you've got a true treatment failure of a nitramidazole, you know, the problem, yeah, no, I'm not sure. I would have to look up. I don't think there's anything else listed in the guidelines for a nitramidazole allergy. But if anybody else is aware of something that I'm not, chime in. This was the most fun fact, I thought, that was in the guidelines. There is actually no convincing evidence of a disulfiram-like interaction between alcohol and metronidazole. So I think we've all, for many, many years, been in the practice, if we're prescribing metronidazole, of saying, hey, you can't drink alcohol while you're on this medication. It'll make you super sick. Probably not, frankly. So really no great evidence. Metronidazole does not inhibit acetaldehyde dehydrogenase the way disulfiram does. And the belief, and CDC goes into this a little bit in the guidelines, that previously described cases of reaction really could all be explained by either just alcohol alone or just metronidazole alone. It's not clear that there's a really concerning interaction between the two. So CDC now says counseling to avoid alcohol with metronidazole is unnecessary. If you have a patient who is of age, you do not have to counsel them not to drink alcohol with their metronidazole. Last topic, I want to tell you about some updated recommendations for herpes serologic testing and counseling. So we know that more and more genital herpes infections are caused by HSV1, particularly in young women and young men who have sex with men. So the importance of distinguishing between HSV1 and HSV2 genital infections has really been underscored in the updated guidelines, because CDC is now making more explicit distinctions between how these two types of infection are managed, particularly with regard to counseling and considerations for suppressive therapy. So important to distinguish HSV1 versus HSV2. So HSV1 infections are associated with fewer recurrences, and asymptomatic shedding with HSV1, shedding from the genitalia, really rapidly decreases over the first year of having the infection. Contrast that with HSV2. With HSV2, recurrences are likely. Asymptomatic shedding is common and more persistent. It lasts longer, stays at higher levels of asymptomatic shedding for longer than HSV1. Shedding and recurrences do decrease over time with HSV2 as well, but not as rapidly as they do with HSV1. So our considerations regarding prescribing daily suppressive therapy are going to therefore be different depending on serologic type. So daily suppressive therapy has, of course, been shown with HSV-2 infection to both decrease the outbreaks, decrease recurrences, clinical recurrences, but also for HSV-2, daily suppressive therapy has been shown to reduce the risk of transmission to seronegative partners. And therefore, CDC has been for many years now, encouraging us to discuss and offer daily suppressive therapy to all of our patients with HSV-2 infection to decrease the risk of transmission to sexual partners. Now, that's HSV-2. HSV-1, again, associated with fewer recurrences, viral shedding with daily suppressive therapy for HSV-1 has actually not been studied. All those studies were just in HSV-2. So we don't know with certainty that there's really any benefit in lowering the risk of transmission to a sexual partner of HSV-1 if you're on daily suppressive therapy. Therefore, the recommendation is now daily suppressive therapy in the context of HSV type 1 should be reserved only for those with frequent outbreaks, because again, no evidence that it protects partners. Now, again, this is a guideline. Shared decision-making with your patient is going to take place in every case. If you've got a patient with HSV-1 who's got, maybe their outbreaks aren't that frequent, but they're really associated with a lot of psychological distress or physiologic distress, you can certainly consider daily suppressive therapy for HSV-1 in that patient. But in general, they're encouraging us to think about those two, make sure you know which one you're dealing with, and maybe think about them a little bit differently the way we counsel our patient. So if lesions are present, of course, they should be tested using pretty much PCR is what's more common even than culture now. And again, typing should be performed on the individual lesion. Routine serologic testing for herpes still not recommended, but of course, as we know, there may be clinical scenarios in which it's appropriate. You've got a patient who comes in and says, a couple of weeks ago, I had this thing and it was really painful. I made this appointment, but now it's gone. I'm here now and it's healed up on its own. So if a patient gives you that history that kind of sounds like genital symptoms, sounds like HSV, but the lesions are now resolved or resolving, you can't perform PCR testing, you might want to think about serology in that setting, right? So type-specific serologic testing, if you're going to do it, should be based on the HSV-specific glycoprotein, the G2 glycoprotein. HSV-1 seropositivity, as we know, remains difficult to interpret since it may or may not reflect sexual transmission or a genital infection, right? We know kids can get cutaneous, oral infections earlier in life. So serologic testing for HSV-1 is really not particularly useful, not recommended. Problem is some of our labs kind of just do it. Like if we order 2, they give us 1. And it's information, frankly, I almost wish I didn't have sometimes because I'm not sure what to do with it. But with HSV-2 seropositivity, I used to think, okay, well then I know they definitely had genital herpes if they're HSV-2 seropositive. Serologic testing is positive. Well, not so fast. The issue with HSV-2 testing is that HSV-2 serology actually has really poor specificity. So confirmatory testing should be performed using a different method. If you've got positive HSV-2 serology testing, you should consider, or the recommendation is to do a different method, such as a Western blot or a BioKit to confirm HSV-2. This was actually this is actually not a new recommendation. This was present in the 2015 guidelines, but in this edition, they really called special attention to it and expanded the discussion of index values. So when you do HSV serology, the result comes back to you with this report of an index value. For example, an index value of less than about 1 or 1.1, it will be reported as negative. An index value of greater than about 3 or 3.5 is positive. And then in between those values, between about 1 and 3, is what's considered a low index value and may represent a false positive test. The specificity of some commonly used tests, including the one used at my institution, the Herpes Select, the specificity at these low index values can be as poor as 40%, which is really terrible. So a lot of risk for a false positive. So confirmatory testing really should ideally be done. if you're not able to get confirmatory testing, at least, just be aware of the risk of these false positives, and really interpret your test in the context of your patient's history, their degree of risk, your index of suspicion, and really discuss this with the patient when you're deciding whether you even want to test at all, because it can put some confusing and distressing information out there to have a kind of a low positive that might be a false positive.
Cindy, real quick, for suppressive therapy for HSV2, how long should that be recommended?
Yeah, yet another opportunity for shared decision making. So not forever is the short version, that we do need to be reconsidering with our patients. When do they want to kind of lift up that suppression? Because even with HSV2, over the course of years, the number of outbreaks, the natural history, just the outbreaks become less frequent, the asymptomatic viral shedding and therefore subsequent risk of transmission to partners also becomes less over time. But it's not, I don't think we have great data on kind of what that timeline is, or that it doesn't generate a clear cutoff that, oh, after 2.5 years, you can definitely stop your suppressive therapy. It's really shared decision-making with patients. Try and take it away. You can always give it back, if they continue to have outbreaks. But I think certainly after a few years, it's really appropriate, if not sooner, to have that discussion with your patient about maybe stopping them. And that's what I got. I'm going to skip my recommended practice changes, my practice change recommendations, to do all that stuff we talked about today. Lots of great online resources and reference for you. And again, join us, please, in April, or if you can't join, at least kind of join us virtually for these activities in the future as we move forward. And I'm happy to take questions in any of the time we have left, and I don't have to go anywhere, so I'm good. I know Sarah hit me with a bunch of them along the way, and that's fine.
I know that was great. Thank you so much, Cindy.
questions?
And feel free for people to put their emails in the chat, which I'll save, and we can create a list of people who might want to have other, we will certainly put any reports of the talks we do through NASPAG, and they'll send them out. But any other things that Cindy and I happen to wax poetic on for our adolescent medicine SIG, we're happy to include you all in. But this was awesome. Thank you so much, Cindy. And
thank you all for your participation. I love to see so many people here.
And there's a question about the slides available to the group. I know that they're going to put the video that we're taping today on NASPAG for availability, and I imagine we could link a PDF to the slides as well.
Sure, I can do that.
Thank you, everyone, for coming on an East Coast late night and on a West Coast end of day, and from wherever else. I think there was some people even from abroad. Brazil, look at that, amazing. Love
I'm
that.
honored.
Awesome.
Thank you all for being here. Bye-bye. I feel like there was a time when I knew how to save a chat.
Stellar, it's Ellen. It was really, really great. And you guys are the perfect picks for this. Way to use Zoom to breathe energized vitality into the SIG. Really, really, really well done.
Let's hope so. I'm just reading. I'm like, who said this about being Jan is bejazzled? And of course it's you.
Hey, nice job, you guys.
Is that Dr. Bonnie?
No, it's Dr. Sakato.
Dr. Sakato. All it says is iPhone, Gina. You're just a random iPhone.
You're an anonymous cool person out there.
Hello, my friend.
Hello, my friend. That was awesome.
It was awesome, Cindy. You did great.
Thank you.
Really great.
Thank you.
I want
right,
to be
Sarah,
part
do you
of
know
the
how to-
adolescent SIG.
What's that?
You can be a member.
Okay.
Yes, I will save the chat and have all of the emails, and I will get in some capacity, send this Zoom recording to NASPAG.
Yep.
Excellent. And
done.
I will do my, I can make my slides